Hello, everyone, and welcome to McGill Cares webcast series supporting family and informal caregivers. I'm Claire Webster, a former caregiver, certified Alzheimer care consultant, and founder of the McGill University Dementia Education Program. I work with a dynamic team of leading healthcare professionals to oversee this program, which include Dr. José Moret from the Division of Geriatric Medicine, Dr. Serge Gauthier, McGill University Research Centre for Studies in Aging, and Dr. Gerald Fried, McGill Steinberg Center for Simulation and Interactive Learning. These webcasts are made possible thanks to the generosity of donors. And today's webcast is made possible thanks to Ryan and Dominic Lynham in memory of their wonderful nanas, Stella Pearson and Muriel Wilson. Today, we are going to be discussing understanding and preparing for a telemedicine appointment. My guest is Dr. Maiya Geddes, a clinician-scientist at the Montreal Neurological Institute. She sees patients at the McGill Center for Research Studies in Aging, and she is an assistant professor in the Department of Neurology and Neurosurgery at McGill University. Welcome to McGill Cares.
Thanks very much, Claire. Thanks for having me today.
So we are going to talk about telemedicine and demystify this whole concept in order to educate our viewers, and even more myself, what exactly it is. So can you please define, what is telemedicine? How can people access it? So tell us all about it.
So telemedicine is defined as the real-time interaction between a clinician and a patient at a distance. So this can be either with a video conference, such as what we're doing today, or it can be by telephone. So those are the sort of key things about telemedicine, and it's applied in many different contexts, especially now during the COVID-19 pandemic.
So that means that people will speak to their doctor via their laptop, I guess through an iPhone or iPad. Is that it?
That's correct. Yes. So for the video conference telemedicine appointment, you can use multiple devices. So you can either use a desktop computer, you can use a tablet, or you can use a smartphone.
So how does it work? Do we need to have a special program? Like, is there a Zoom or FaceTime? So how does it work?
Yeah, so before a telemedicine appointment, patients will set up their, if they're going to use video conference software, they're going to set that up in advance of the appointment, often with administrative help from the center that's administrating this, the telemedicine appointment. And so that will happen in advance of the meeting. My personal practice is in neurology, and I see patients who often have cognitive impairment. So one of the key principles of telemedicine with my patient population, so individuals who are living with cognitive impairment or dementia, is that they have a care partner involved in setting up the telemedicine visit. So it's really critical that either a spouse, family member, friend, loved one, or caregiver is part of the setup and instrumental throughout that whole telemedicine visit. And we can talk a little bit more about why that's so important later.
So when you said there's someone that to assist, because for instance, a lot of the population are people over 75. The whole idea of Zoom, I see patients as well do consulting this way. They often ask, a family member to come over and help them. Sometimes it's a grandchild to come over and help them. What if there's no one there to help them? I mean, in many offices, is there, a person that will help them step by step over the phone, or how do you set this up?
Yes. So depending on the individual situation, we offer assistance via the phone with the administration who sort of helps set up the appointment. But with advanced cognitive impairment, it becomes more and more critical that someone is actually on site with the patient. And helping them actually sort of set up the appointment, download the necessary software, because most tools now, this might change in the future to make them more easy to use, But at present, there needs to be sort of a download and setup so that we're using encrypted software. So we need to use software that protects patient privacy, because this is now a new form, and patient privacy and data security are become important. So we need to make sure that we're using the correct types of software, which is why it's so important to have that care partner downloading and setting up this software that we're going to use for the video conferenced appointment.
Okay, so now that everything's set up, how can people best prepare for the appointment? Like what are like some best practices?
Yeah, so the first thing to sort of know, as I mentioned, the most critical piece is that we're going to need, as clinicians, we really need to hear a history from the patient, but also a collateral history from someone who knows the patient really well. And this is because sometimes cognitive disorders can affect somebody's awareness of their own deficit, of their own symptoms. So it's really important to get multiple perspectives. So in the context of an assessment of someone who has cognitive impairment, the clinician is going to want to speak to both the patient, and then with the patient's consent, we would speak to a caregiver separately, either on a private line at a different time in advance or after the appointment, or in a different room in the house that's private and that they can really disclose any information that they think will be important. And of course, all of this is done with the patient's consent, in addition to the whole telemedicine appointment itself, because there are some limitations and there also are some benefits.
Okay, that's a very important point that you made. And I think that doesn't only apply to telemedicine. I think the importance of involving the family member or the care partner, whoever that person may be, in terms of getting some feedback about what are the signs and symptoms that they're seeing. Because oftentimes, like you just said, the person who is showing signs and symptoms of dementia may not recognize it in themselves. They may be in denial. I remember with my mom, she absolutely refused to even want to go and see a doctor, right? So I had to kind of forcefully take her. So the input of the family or informal care partner is very important.
Yes, it's really this trinity between the clinician, the caregiver, and the patient, and that's sort of the team. That's kind of the foundation or the team of care that we need in order to provide the patient with sort of the optimal and gold standard of care. And the reason for that, as I mentioned, is because sometimes disorders of thinking can actually impact the brain regions and the brain circuits involved in self-awareness. So our ability to tell whether or not we have memory or cognitive impairments. And so that's why it becomes so critical.
Okay, but here's a tricky question. So you're saying that you need to have consent from the patient. But what if the patient is in denial, the patient doesn't want to see the doctor and will not give their consent?
So it depends. We always have to think about safety as well. And there's this question of capacity. Is the patient able to have enough capacity to consent? So that gets into sort of a whole other discussion about capacity and the ability to consent. And that becomes different for different types of things, whether it's financial capacity or ability to sort of make decisions about medical care. So if the patient has capacity, then we do need to involve their consent. And often this is why it's so critical to build a trusting relationship between the clinician and the patient, so that they really know that we have their best interests at heart. And I've had very, very few instances where patients have not wanted to involve family members. And family members are almost sort of an added sort of layer of a patient's life, because they're integral in just their day-to-day activities. So, building trust is a really key part of that. But if the patient has capacity, then we do need to have their consent throughout. And if they don't, that becomes a whole other kettle of fish where we think about safety and things like that.
Okay, so let's talk now about the assessment that you're going to make. First of all, I'm assuming that the environment that the person, where you're sitting is important, that there's no TV going on in the background, that there's no radio, there's little distraction, right? Like a quiet area. So take us through that, and then also take us through how is the assessment made on a computer?
Yeah, okay, absolutely. These are really good questions. So it's really critical when you set up. So if a family member and a patient are getting ready for a telemedicine visit with their cognitive care provider, you should have a pen and a paper handy. You should be in a quiet room without distractions, so no radio, no television. Ideally, have the lighting in front of the patient's face. So don't sit in front of a window because you'll have backlighting and it becomes a little harder to see the patient. So you want to be private room and have these things available. You also want to make sure that if the patient needs any corrective devices like hearing aids or glasses, that they're made available. So we're really giving the patient the best shot of understanding what's going on during the interaction to the fullest extent and performing their best on any cognitive tests that might be administered. And then you want to hide any cues about time or date, because these might be some questions that are asked by the provider. And so you really want to make this as valid and quiet an environment as possible and ready for the cognitive assessment by telemedicine. And then in terms of your device, you want to have, if it's possible, to actually plug in your computer so you have a wired connection instead of a wireless connection. That's slightly better. You can also do a Google speed test just to check that you have adequate speed to perform the assessment via video conference, for example, because if we don't have enough speed, that can influence, for example, when we're doing our video conference physical exam, we look for things like tremor or other things. And so we want a good speed so that we can really detect, we have the sensitivity to detect any things on the exam as clinicians. And so once you're in sort of this quiet, ideal environment, you want to sort of sit so that your face is sort of easily visible in the camera. You can make eye contact. When you log on at first, you might even want to close your self view so that you're not distracted by your own image, or the patient's not distracted by their own image. And when you start the visit, it might be helpful just to prompt the clinician by providing them with your phone number, so that if there's a technical failure, let's say that your sound doesn't work, or let's say the whole thing crashes, the clinician can call you right back, and that can, get rid of a little bit of frustration that people might feel with technical failures, which can happen when you're using telemedicine.
How long does the appointment last? And also, are you just asking the person questions, or are they going to have to use their computer? And how does it work?
So there's different stages of the interview and different stages. It depends on each provider. For myself, it's good to allot about an hour and a half of time. Sometimes it can be even longer. So I will sometimes be talking to family members before or at different times, or even in different places. If, the patient gives consent for the kids to give their input or concerns, then I'll sort of get a history, we call it, from different parts of the family and different parts of the care team. And then the actual hour and a half is sort of broken up into three main parts. Well, actually four main parts. The first part is really talking about a history, which is just telling the clinician when and what symptoms started, what was their course over time, how did they change over time, and then the clinician will sort of ask some probing questions about that to really understand everything about thinking, mood, behavior, sleep, some physical signs and symptoms that the patient might have experienced. And so that story, the physician will want to gather both from the patient and from the caregiver. And then there's a second part of the meeting, which is a cognitive assessment. So we use validated cognitive tools that we can administer remotely. Sometimes this involves screen sharing so that people can see different stimuli, and then I can ask them questions. And I think sometimes, just to put people at ease, this is really the same as a cardiologist taking a blood pressure. So as a behavioral health specialist, which is what I am as a cognitive neurologist, I use the cognitive assessment to really get a snapshot of how someone's thinking is in different domains, their memory, attention, language. I want to know each of these things in detail. And it's the same idea as it's not a quiz. It's really just the way a cardiologist would take a blood pressure, so that I can get that snapshot. And that's done usually with a patient by themselves. So that's the time when it's private, so the patient feels really at ease and and like they're not being tested. So that's really important. So if you're coming in, that you will be by yourself and, made to feel at ease for that part. And then the next part is a video conference neurological exam. So we have modified the neurological, the physical exam that's usually done in person, and we do the parts of it that we can via video conference, via telemedicine. And then at the end of that, we usually involve the family member to hold the device if it's a tablet or smartphone, so that we can see the patient walking. So we want to see you walking at the end of the meeting, because that's actually part of the neurological exam. And after that component, we come together. So this is now the individual who has cognitive impairment, the caregiver, and myself, and we sit down and we talk about an assessment and plan. So, okay, where are we at? What information did we gather that day? What is my thinking about what's going on? What additional data might I need to help make a diagnosis or to guide the care plan? And then at that point, it's really an opportunity for patients and family members or caregivers to ask questions. So write your questions, come with questions that you might have, so that at that point, you can ask all of your questions and those can get addressed. And if you forget to ask a question, don't worry, because continuity of care is really important. So there will be follow-up visits. So you can always ask in the future if you don't make it. Remember to ask your questions at that point. And also, clinicians like myself will write a long and detailed note about their impression, their plan, and they'll send it to the referring physician, which is often the family doctor. And also, the care plan can also be made available to the patient. So if you want, you can always ask your physician, can I have some information about my plan of care, so I remember all of the things that we talked about today.
So it sounds very, very extensive, very thorough, and it is long. And so I'm just wondering, for somebody who has, some cognitive impairment, are there breaks available during the appointment? What happens if it becomes too tiring for the person to stay on for this, I guess almost like a 90-minute session?
Yeah, so there are, for sure. So if it's ever too taxing for a patient, the visit can be actually broken up into multiple sessions. So it's not necessary to gather all of this information in one go. So if it's not the right day, or if it's not an opportune time for the patient, or if there's a technical failure for some reason, then the visit can always be broken up into segments. And so it's really important when we're assessing cognition that someone has the opportunity for breaks, that if they want to take a break altogether and they want to try another day, that they have that opportunity as well. The patient might have opportunities for breaks. For example, if the clinician or the neurologist is speaking to a caregiver, that's an opportunity for them to sort of take a break if there's that punctuation.
Now, for a lot of people listening, do most doctors' offices offer telemedicine, or is it just something that's starting to become developed?
I would say that it's really so it has been around for a little while. For example, stroke assessments have been done via telemedicine to be able to reach people who have geographical constraints. But it's now being widely adopted. So since the onset of the pandemic, people are using telemedicine much more than they have ever in the past. So there's been sort of this unbelievable explosion of use of telemedicine. And the reason that we're doing that is to keep patients safe, because individuals with cognitive impairment have a number of risks for contracting COVID. So they're older usually, and just having a diagnosis of cognitive impairment actually puts you at an even greater risk. And so in an effort to keep people out of hospital and sort of minimize this risk, telemedicine has really taken off. And so that brings us to sort of the advantages of telemedicine, which is that you can do it from the comfort of your own home, and it's very convenient. There's no waiting rooms. There's, no sort of driving in winter to get to your doctor's office. It allows people who have geographical constraints to access a specialist. It allows people with mobility constraints to access a specialist easily. So there's definitely some advantages. The disadvantages are that it can feel a little bit less personal. So empathy in medicine is really critical. patients in general actually accept telemedicine. So they've done studies looking at this, and in general, it's very well accepted. It sort of loses points for sort of human touch and things like this, like the sort of those important empathetic and feeling that your physician cares about you is actually correlated with your outcome. So it's actually empathy in medicine is really, really important. There's also some limitations in terms of the kind of tests we can do. We can't, for example, check reflexes when we're at a distance. So we have to modify what we do in terms of some of our assessments. And although there's lots of information saying that the tools that we use for the cognitive assessment are valid at a distance, there's just not as much data. So the validation studies, that kind of those rigorous studies are still being done. So there's still work to be done.
Do you see this as the future of medicine?
I don't think it's going away. So I don't think it's the entirety of the future of medicine. For example, sometimes we'll involve students. So there'll be sometimes learners or trainees that join us with the patient's consent for telemedicine visits. And in education, I think that it's a tool, but it's not everything. I do think that in future, we will probably offer it to patients who have seen us once in person as follow-up and a follow-up option. So in follow-up, there's a little bit more flexibility. For a first visit, we really need a video conference assessment. But once we've done the neurological exam and cognitive tests, we can do some of our follow-up visits just via telephone. So that can be really helpful for an older adult, just to pick up the telephone and speak to their physician. And I think at least in my own practice, I'll continue to offer follow-ups. I'll give patients the option so they can have in-person or telemedicine, which means phone or video conference, depending on their preference and where they live and their life circumstances.
Dr. Geddes, thank you so much for joining us today. So informative.
Pleasure to be here.
Please join me on Wednesday, March 24th for a very special edition of McGill Cares, a journey through the diagnosis of dementia. My guest will be Dr. Serge Gauthier, Director of the Alzheimer's Disease and Related Disorders Research Unit of the McGill University Research Centre for Studies in Aging. He is also professor in the Department of Neurology, Neurosurgery, Psychiatry, and Medicine at McGill. He is currently leading the initiative to produce the next two editions of the World Alzheimer's Reports on the crucial and interrelated topics of diagnosis and post-diagnostic support. I'm very excited to be part of Dr. Gauthier's team on these reports. Dr. Gauthier was appointed to the Order of Canada in 2014 and the Ordre National du Québec in 2017 in recognition of his contributions to advancing our understanding of Alzheimer's disease and dementia. Dr. Gauthier will provide a detailed presentation on the signs and symptoms of dementia. He will discuss how to best prepare for the first medical appointment and what to expect, how a diagnosis is made through various tests, and what individuals and care partners need to do immediately following a diagnosis. This will be a very special edition next week. This webcast is an initiative of the McGill Dementia Education Program, which is funded by private donations. Once again, I would like to thank Ryan and Dominic Lynham for their donation in memory of their wonderful nanas, Stella Pearson and Muriel Wilson. To make a contribution or for more information about our program, please visit us at mcgill.ca/dementia. If you have any topics or questions that you would like us to address, please email us at dementia@mcgill.ca. Thank you for tuning in today. Take good care of yourselves and of your loved ones.